Hello, listeners. From the RSNA, this is the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath, and I am a radiologist from Dallas, Texas. In this podcast, we explore research advances and technical developments in cardiothoracic imaging through conversations with our authors, our editors, and experts in the field. Enjoy! Hello again, listeners, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath. On today's episode, we will be discussing a recently published systematic review from our colleagues in the Netherlands. The paper is titled Correlation Between Cardiac MRI and Voltage Mapping in Evaluating Atrial Fibrosis, a Systematic Review. The lead author is Dr. Miranda Bijvoet, and the senior author is Dr. Casper Mihl. In this paper, the authors sought to synthesize the current literature pertaining to the following question. Is there an association between late gadolinium enhancement on cardiac MRI, low voltage areas on electroanatomic mapping, and atrial fibrosis at histopathology? 22 studies were included in the systematic review. Of these, 19 demonstrated a correlation between LGE on MRI, low voltage areas at mapping, and atrial fibrosis on PATH. Of note, substantial heterogeneity was present between these studies, including differences in study design, patient demographics, LGE interpretation and post-processing, as well as mapping techniques. So, is there truly a correlation between LGE imaging, electroanatomic mapping, and path-proven atrial fibrosis in patients with atrial fibrillation? Well, I had the privilege of speaking with the lead and senior authors of this paper to answer this question and more. Let's jump into that conversation now. All right, welcome back, listeners. I am now joined by the lead and senior authors of our featured paper, Dr. Miranda Bijvoet and Dr. Casper Mihl. Miranda and Casper, welcome onto the podcast.
Thank you, Praveen. Thank you for inviting us.
Thank you, Praveen, for having us. Great.
Of course, thank you both. And as a reminder to our listeners, the title of your paper is as follows: Correlation between cardiac MRI and voltage mapping in evaluating atrial fibrosis, a systematic review. But before we get into the paper, why don't we learn a little bit about you both? Tell us a bit about yourselves. Where are you from? Where are you currently working? And what are your areas of research interest? Miranda, why don't we start with you?
Yeah, thank you. As you said, my name is Miranda Bijvoet. I'm a cardiologist in the Netherlands. I work at the Maastricht University Medical Center. And I combine my clinical work as an imaging cardiologist with research. My research is mainly focused on the role of MRI in the treatment of cardiac arrhythmia. And just to give you a little view of my daily life, I study the imaging characteristics of ablation lesions. And for instance, with LGE, late gadolinium enhancement MRI, which is the focus of the current systematic review. But also we perform CMR-guided atrial flutter ablations in our hospital. I don't know if the listeners are familiar with this innovative treatment. Me and Casper, we are both part of that clinical team in our hospital. And with this treatment, the ablation is done completely inside the MRI scanner. And we can study the ablation lesions directly after they are applied in the heart, since the patient is already inside the MRI scanner during the entire procedure. So this is a very nice opportunity for me as an imaging cardiologist to combine clinical work with research.
Amazing. Thank you, Miranda. And Casper, what about you?
Hi, Praveen. My name is Casper. I'm a radiologist in the Netherlands, and I also work at the Maastricht University Medical Center. I completed my residency training in 2016, followed by 2 fellowships in both abdominal and cardiovascular radiology. And I've received some additional training in cardiovascular imaging at the Royal Prince Alfred Hospital in Sydney, as well as the Alfred Heart Centre in Melbourne, Australia. I did my PhD on the optimization of scan and contrast media injection protocol imaging optimization in coronary computed tomography. And my primary emphasis in research is focused on multimodality imaging of the heart with a special focus on supraventricular arrhythmias and the optimization of scan and contrast media injection protocols in CT.
Spectacular. Thank you both again for joining us. Why don't we dive into some background behind the systematic review? So I have to say, from my end, it's an extremely elegant systematic review. And the question that was sought to be answered was as follows. What is the correlation between late gadolinium enhancement cardiac MRI and voltage mapping in evaluating atrial fibrosis? So as part of the background, could you help us describe why understanding atrial fibrosis is so important to managing our patients with atrial arrhythmias?
Well, just to give a little bit of background, the heart is constantly adapting to its environment, whether this is in response to certain comorbidity of the patient or medical treatments or just aging. And at the level of the atria, we call this atrial remodeling. Maybe this is just known by the listeners, but to give a little bit of background. And this atrial remodeling is characterized by structural changes as well as electric and mechanical alterations. And of the structural atrial remodeling, their atrial fibrosis is actually the hallmark of this. Now, to answer your question, it's important to know the extent of this atrial fibrosis in one patient because it has shown that it is associated with cardiac dysfunction, the amount of atrial fibrosis, and also associated with comorbidity, for example, the risk of stroke and mortality. So that's why it's clinically important to know this in this particular patient. It has also been shown that when a patient suffers from atrial fibrillation or another supraventricular arrhythmia, and you treat her or him with an ablation, then the amount of atrial fibrosis which is present is associated with the chance of recurrence of that arrhythmia after the treatment. So these are two reasons why we as a team believe it's important to study this and to find answers in this regard.
Great. So good clinical context there. Let's translate over to the imaging side now. Many of our listeners are definitely familiar with late gadolinium enhancement imaging and MRI, but for left ventricular fibrosis, could you describe some of the technical similarities as well as differences of LGE imaging that's used for atrial fibrosis?
Yes, Praveen. Most of the listeners will probably know late gadolinium enhancement imaging is used to evaluate myocardial fibrosis, whether ventricular or atrial. Hyperenhancement at LGE imaging is not equivalent to fibrosis. It's merely a reflection of tissue characteristics, a shortening of T1 relaxation time, resulting from focal accumulation and washout of the contrast agent. But it's yet impossible to differentiate between LGE caused by replacement fibrosis, possibly iatrogenic scar. So it's important when imaging atria compared to the ventricles that not only is the atrial extracellular matrix more complex, most importantly, the thin atrial wall is more prone to partial volume effects. And imaging the atria requires high resolution while maintaining a sufficient signal-to-noise ratio. And in practice, this still proves to be rather complex.
Yeah, at our institution, we really only reserve three-dimensional LGE imaging rather than two-dimensional LGE imaging for evaluation of the atrium for the exact reasons you described for significant partial volume averaging. I presume that is what y'all do clinically at your institution as well. Is that correct?
Definitely, both clinically and also all the included studies in the systematic review, they all perform 3D LGE MRI of the atria.
Perfect. And as we know, that comes with some benefits, but also some caveats, which we'll get into a little bit later in our conversation.
Absolutely.
Yeah.
I'd like to bring in a discussion now about the electrophysiology side of our background. You mentioned in the paper that histopathology is really the gold standard of evaluating fibrosis in any structure, including in the atria, but it's really very difficult, often impossible to obtain. As a surrogate, our electrophysiology colleagues often perform invasive electroanatomic mapping. There are many imager non-electrophysiologists in our audience that are likely unfamiliar with the procedure. So could you briefly describe what electroanatomic mapping is and how the results are used for management of patients with atrial arrhythmias?
Yeah, definitely. Well, during an invasive electrophysiological procedure, then the cardiologist place catheters inside of the heart to measure the electrical properties of the myocardium. Now, as I said before in a previous question, with atrial remodeling, structural as well as electrical changes occur. And atrial fibrosis leads to actually a decrease in the bipolar voltage, which you can measure in the myocardium. And the threshold below 0.5 millivolt is usually considered to indicate atrial fibrosis, also in the included studies in our systematic review. Now, in practice, during electroanatomic mapping, this catheter with multiple electrodes is used to create first a 3D anatomy of the targeted cardiac chamber, for instance, in our case, the left atrium, and then a color-coded map is created of the bipolar voltages to show the extent of atrial remodeling, or when indicated the location of previous ablation scar if the patient has already had a previous ablation. And this map can then be used as a roadmap for catheter navigation and also for the ablation itself. And actually, currently worldwide, 97% of all electrophysiological studies are guided with this electroanatomic mapping. And if you don't mind me translating this a little bit back to our review, I believe it's important to realize that the quality of the reference test, which is in fact electroanatomic mapping, as I just described, the quality of this test is highly dependent on the amount of voltage points which are measured to create this electroanatomic map, as well as the catheter used. And to give you an example, nowadays all the cardiologists use a high density mapping, and then they measure around 2,000 points inside of the left atrium. So it's a high amount of voltage points that they acquire. And you can see this also in the recent studies that we included in this systematic review. While all the older studies prior to 2017 mostly, they only had around 100 data points per left atrium. So you should be aware that this actually determines the spatial resolution. This is, I think, a term that most radiologists will be more familiar with. So the spatial resolution of the reference test also defines the accuracy of your reference test and the comparison with MRI. So this is why we focus an entire table on the EP-related parameters of the included studies, and we don't only focus on the MRI parameters.
There might be just a final point I would like to make in addition to the explanation. As Miranda correctly stated, electroanatomic mapping is considered to be the gold standard for evaluation of atrial fibrosis. However, we do have to bear in mind that this is an invasive procedure, and that when the patient is already undergoing an ablation procedure, this is a very good tool. However, to use electroanatomic mapping to assess the atrial fibrosis by default in a patient who does not need an ablation, this is regarded as a rather invasive procedure. Which is why it's so important to assess whether MRI is feasible and useful as a non-invasive alternative.
Perfect. Yeah, I think that's a great way to dovetail into the discussion about the results of the study now. But to reiterate, the main clinical question being asked is, can we identify a correlation between late gadolinium enhancement MRI and invasive electroanatomic mapping in patients with atrial arrhythmias? So perfect. That may be at risk of oversimplification, of course, and we'll get into some of the nuances of that too. But let's jump into the systematic review now. In the final analysis, you've included 22 studies, which comprised of a little over 560 patients, of which 73% were male. Once again, I may be at risk of overgeneralizing here, but based on these data from these studies, you conclude that there is indeed a correlation between high signal at LGE imaging and low voltage areas at electroanatomic mapping. So basically, LGE abnormalities correlate with our surrogate for atrial fibrosis. I want to dissect this a bit further by starting with the image acquisition component. How are these cardiac MRI techniques similar, and how are they different between all of the studies that were included in your review?
Just let me start off with addressing the similarities between cardiac MRI acquisition of the included studies. So as just mentioned previously by Miranda, all the studies use 3D acquisition, EKG and respiratory navigated to assess the fibrosis. And all studies performed imaging 10 up to 25 minutes after contrast media administration, using an equivalent weight-based dose, except for 2 studies that included a fixed dose, regardless of the patient's body weight. Most of the included studies use a 1.5 Tesla machine, whereas on 6 out of 22 studies actually used a 3T machine. Now, subtle differences in image acquisition do matter and are explained in detail in the table on the MRI-related parameters. The most important heterogeneity between studies results from the post-processing strategies. With regard to the difference, 3 important categories can be defined. First, the different thresholds being used to define atrial fibrosis on LGE imaging. Secondly, whether or not the signal intensity is normalized to the blood pool. And last, what is the method of correlation between the data from the MR and the electroanatomical mapping? Is it assessed by looking at the left atrium as a whole, or is it compared to each voxel or for different regions? This is important implications for the interpretation of the results, but I think we might discuss this later in the podcast as well.
Yeah, thanks for alluding to some of the questions I have about that, Casper. While we do clinical 3-dimensional late gadolinium enhancement imaging at our institution, I have not encountered a lot of institutions, including my own, which normalizes signal intensity to the blood pool. Could you describe a little further as to how that's practically performed?
Yeah, definitely. Well, normalization of late gadolinium enhancement to the blood pool, it's actually an important step to minimize the interpatient variation. I think as many listeners will know, the obtained signal intensity of an LGE image is influenced by many patient-specific parameters, such as the patient's heart rate or renal function or cardiac function. And to normalize to the blood pool, you will correct for these pharmacokinetics of the contrast agent within this one patient. So how is this performed? You asked before. So after the scan is finished, for each voxel, the left atrial wall, the signal intensity is recalculated, so to speak. So then the signal intensity is no longer expressed as an absolute value, but as its ratio towards the patient's own blood pool signal intensity. And this has been done in the studies that we include in two ways, roughly, either by using the IIR, the image intensity ratio, or the so-called NLA, the normalized left atrium. And just to give you a little bit of detail, when the studies would use IIR, then the signal intensity of the LA wall is divided by the mean signal intensity of the patient's blood pool. And when the studies use NLA, then the signal intensity of the left atrial wall is expressed as the amount of standard deviations above the mean signal intensity of the patient's own blood pool. So you will find these two terms also in the table of our systematic review. So it's nice to understand where the numbers are coming from. But either way, it's important to minimize the interpatient variation of the found signal intensity.
Excellent. Yeah, that's extremely helpful because when on surface level, we look across these exams and they generally perform a three-dimensional late gadolinium enhancement pulse sequence, it seems to be the same across all, but in fact, there's quite a bit of variability in terms of not only how the image acquisition is performed, but how the image data are interpreted. So perfect. I think this is a great start to the subsequent discussion we'll have. I want to transition now to the results component about electroanatomic mapping. Can you describe how the electroanatomic mapping procedures were similar and were different across the studies that were included in your review?
Part of this was already briefly highlighted by Miranda in the previous questions. As she mentioned earlier, the most important differences are the type of catheters used. So in addition to that, the amount of voltage points that are measured. So this ranged from a mere 90 points per left atrium with a 4-pole catheter to more than 2,500 points per left atrium, acquired with a high-density mapping catheter. And this was obviously also taken into account when grading the quality of the study in our Quadrats 2 analysis. The risk of bias of the reference standard was considered higher with a lower spatial resolution of the electroanatomical mapping. Now, in addition to this, the heart rhythm might also have influenced the measurements. Half of the studies included measured bipolar voltage strictly during sinus rhythm. 3 studies, on the other hand, strictly during atrial fibrillation. And in 3 studies, the rhythm was actually mixed.
So within population studied, some had sinus rhythm and some had atrial fibrillation, and then they just combined all the found results.
And in 3 additional studies, this was not reported.
Yeah.
So finally, to understand the results, about half of the studies used bipolar voltage as a continuous value to compare MRI results, and the other half used a cutoff value below 0.5 millivolt, being the most used threshold.
Yeah.
Excellent. Okay, so generally speaking, the more points that are measured or more voltages that are acquired, the higher the spatial resolution, and more likely the higher the fidelity of the data. But obviously that's not the case across the entirety of studies due to, I'm sure, a variety of reasons. Let's now synthesize some of the imaging and the electroanatomic information. You've mentioned already that there are a few approaches for correlating the LGE findings with the electroanatomic mapping. I believe they're a global disease extent approach, a rough spatial correlation approach, and then a true point-by-point mapping approach. Why are these 3 approaches different from one another, and do they answer different questions altogether, or are they all intending to answer the same thing?
Yeah, thank you for asking this. We believe that the chosen method of correlation between MRI and electroanatomical map is of great importance. And I would like to explain the 3 methods because the listeners will be unfamiliar with these terms, obviously, because we were actually the first to introduce those terms. So I would like to highlight what we mean by these. So as you said, global extensiveness of disease, which was used in 4 studies. These studies calculate the percentage of the whole left atrium with atrial fibrosis. And they do this both by LGE MRI and with low voltage areas. And then they compare these 2 percentages to each other to see whether there's a correlation between the two different diagnostic modalities. And that's why we, as the authors, call it a global extensiveness of disease, because this is what you can study with this. Now, another strategy is what we called rough spatial correlation. This was used in 9 studies, and these studies all divided the left atrium into regions with and regions without LGE. And then they compared the electrophysiological parameters of these regions. But mind you, in some of these studies, they only calculated the mean bipolar voltage of all voltage points within a certain region. And you might understand that the global assumptions like that will have potential to induce errors in the judgment of the comparison. And then the final approach is through point-by-point matching, as you mentioned. And with this approach, each individual cardiac MRI pixel is matched to the closest voltage point within the map. And 8 studies gathered information about spatial correlation in this regard. And then you ask whether one approach is better or more accurate. And we elaborate in more detail on this in the publication. But I think it's most important that the correlation method you choose matches the research objective. So when you would like to determine cutoff values or ablation gaps, then a point-by-point comparison is desired. But when you would like to determine the extensiveness of disease, perhaps to aid in pre-procedural planning of this patient, just to know how much of the left atrial remodeling is present in this patient, should or should I not go for ablation, for instance, or you want to use it as a prognostic marker, then quantifying atrial fibrosis per region or per left atrium as a whole might be indicated, because then you are less influenced by the very small regional assumptions that you have from the alignment of the two methods.
Yeah, wonderful. I think that description helps a lot of us who aren't as familiar with some of the nuance behind linking the cardiac MR data with the invasive electroanatomic data to answer a specific question. As you allude to, each of those modalities helps answer a different question, and each, therefore, has different accuracies. As we've kind of discussed through this conversation so far, there's a general idea behind cardiac MR and electroanatomic mapping and correlating the two, but there's quite a bit of heterogeneity in terms of how each of those can be performed. There's more heterogeneity beyond just the exams in terms of patient demographics, as well as you mentioned, the correlation approach that may be taken to answer whichever the research question may be. With this in mind, I have to ask, is it fair to say that LGE imaging truly correlates with atrial fibrosis as measured on anatomic mapping? Or is there just too much heterogeneity to make that conclusion definitively?
Praveen, you're absolutely right. We strongly agree with the fact that there is indeed a large heterogeneity between the included studies. And I hope this systematic review also provided the reader with 2 important messages. First of all, the current existing literature presented in this review does suggest that a correlation exists between high signal intensity at LGE imaging and low bipolar voltage at electroanatomical mapping when assessing the atria. But also, the clinical and technical methods between the included studies varied substantially, hereby hampering the interpretation and exploration of the study results, which is, to us, I think, exactly why it is crucial that future studies may make uniform choices at both cardiac MR and electroanatomical mapping, as well as matching the method of correlation with the clinical research objective in mind.
You mentioned future studies that may be coming out that help clarify some of the questions that are born from your systematic review. Are there any specific future studies in mind that either you both are participating in or you're familiar with, or any future studies that you would like to see performed to help clarify some of these questions?
Yeah, I think in theory, studies that use histopathology as a reference test would be of high value. But as you mentioned, when you want to study human beings, then this is a difficulty. So in the absence of that, we would really strive towards a more homogeneous field of research when it comes to studies on atrial fibrosis. And I think this will only be realized when different study groups decide to use the same methods in post-processing as well as acquisition. There's not a typical study that we would like to discuss right now that we are involved in, but I think it's important throughout the future studies to be aware of all the different aspects, both from MRI perspective, which I think a lot of studies are aware of the heterogeneity on MRI front, but also to be aware of the choices that you can make regarding the reference test being bipolar voltage mapping. So.
in a way, we could maybe say that the conclusions and limitations that we've mentioned in our systematic review are the future directions for studies to come.
Yeah. Also, in the end of the manuscript, we actually give some tools, a blueprint for future studies, which they might take into account when they set up new studies.
Yeah, that's excellent. I think there are a lot of clinical imagers out there that may have interest in applying some of these questions to their own clinical practice, and something that may be helpful to them as well as understanding how you both implement cardiac MRI into your practice and management of patients with atrial arrhythmias. I know you mentioned that you all do in-magnet ablations for real-time evaluations of fibrosis modification. Can you go into a little more detail as to how your program functions, some troubleshooting that may be helpful for others that are out there that may be interested in performing something similar?
Of course, I think it's important because the work that we did in the systematic review and this topic, we can directly translate to the CMR-guided flutter ablations, or at least we study different tissue characteristics. For instance, the edema sequences, or there are different ways to image the tissue, and LGE MRI is one of those. I think the unique chance that we have here in our center is that we can not only study chronic lesions after ablation, because that has been performed more often, but also to study the acute ablation lesions. And the reason that we are highly interested in this research field is that if we would be able to differentiate transient edema from dense and transmural scar during the ablation, because this is the most important value and endpoint of an ablation, of an RF ablation in cardiac arrhythmia. If you could acquire durable transmural lesions, then the risk of recurrence of arrhythmia is lower and lower. So if we would be able, by use of MRI, to differentiate between transient edema and dense transmural scar, and if there's too much edema and not enough dense scar, then this might in the future increase the efficiency of these therapeutic treatments. Of course, this is all, well, this is our aim, our dream future, and we need all this research to find out whether this is actually feasible, or this is it's a dream, or it's
it's a very exciting field for both radiologists and cardiologists to be in, and more specifically to explore together, basically.
I think just what I was just thinking, because this CMR guided flutter ablations, you need to have a business plan for that. You cannot just do ablations in any MRI scanner. You have to transform a diagnostic setting into a therapeutic setting. So as you mentioned, Praveen, before, like, if it's not the case in your hospital to just start with this type of research, then even our systematic review might aid in just a little step towards the imaging which we find most efficient. As you said, in your center you do the 3D LGE MRI of the atria, but you don't do the normalization to the blood pool. So this might only be small steps to very easily adjust your post-processing and recalculate these findings, and this might aid on a larger scale this research field, hopefully.
Yeah, it's extremely exciting what you're describing. I feel like I already have hundreds of questions more to ask about how to explore those types of fields, but we only have so much time in our conversation. It's been fantastic thus far. Any final thoughts before we conclude?
Yeah, I think just that we are incredibly grateful for you and the editorial board of the Radiology Cardiothoracic Imaging for inviting us and giving us the opportunity to elaborate on our research. And me and I think also Casper, we really enjoyed the conversation and your inspiring questions. Thank you.
We really hope the audience was engaged and that our systematic review, as well as this podcast recording, has highlighted the opportunities and also the challenges in this research field. Yet a lot remains to be unknown within this field, which gives us the opportunity to do more research on this topic.
I couldn't agree more. And Miranda and Casper, thank you both for dedicating your time and your expertise, joining me on the podcast today. It was really a fantastic conversation. Once again, truly thank you from me and the journal and really all of the listeners out there. Speaking of our listeners, thank you all for tuning in. If you like what you hear from us on the podcast, please rate, review, and subscribe to us. Until then, see you.
Bye-bye.
Thank you.
Take care.